Hello, and thank you for joining us. Innovation is such an important part of who we are here at NuVasive and inspires us in everything we create and do. We are proud to be the company that provides you technology created with better outcomes in mind. In cervical, anterior, posterior, complex, pediatrics, and enabling technology. Let's start with Pulse today. The Pulse platform, commercially launched last summer, is now in ORs around the world. Our integrated enabling technology platform continues to make an impact, with application in 100% of spine surgeons, and we are just getting started. To tell you more, here's Chris.
We are seeing great success with surgeons across the globe who are utilizing the Pulse platform. This technology is helping enable the best possible outcomes for every procedure, from large, complex deformities to single-level fusions and everything in between. It is truly the iPhone of the OR, compiling the technologies you need into one seamless platform and maximizing efficiency by completely integrating with one another. For example, using just the C-arm, you are able to stitch together a full-length X-ray intraoperatively and perform sagittal alignment measurements. You can monitor your screw EMG responses from the instruments you are navigating. And all of the systems that require infrared tracking, like navigation, LessRay, and Bendini, are powered by a single camera. That is the power of integrated technologies. To capitalize on maximum efficiency, we recommend pairing Pulse with the cutting-edge Siemens Healthineers CO Spin. Not only does the system perform 2D and 3D imaging in one, which further drives down the number of systems in the OR, but NuVasive also has a strategic partnership with Siemens, so there are enhanced capabilities when pairing the two systems together. We are also excited to announce that as of last November, Pulse has been part of our world-class surgeon education program. On either coast, at either experience center, you can learn the proceduralization of Pulse and how it can further enable your existing procedures, designed to make them even safer, faster, and more reproducible. Now, let's see Dr. Zach Temple and Mike Cashman from Mayfield Brain and Spine leverage the Pulse platform in their cases.
We talk about the importance of adopting new technology and the inherent challenges. I mean, you have a pretty powerful story about that, going from an open surgeon to a less invasive surgeon.
Yeah, it has been a long journey. I mean, the evolution of image guidance and using all the other systems, it has been an evolution over the last 10 years. And I think Pulse is the thing that kind of brings it all together for me a lot. And in adopting that new technology has been very seamless and easy with this, because it's a lot of the same things that we've used before, but it's kind of integrating it into that one platform.
And that's the key, for what Pulse is and how it distinguishes itself from other products, quote unquote, in the market. But really, if you think about it, Pulse is in a market on its own. There's nothing out there that has all of the capabilities of Pulse, right? And where Pulse really separates itself from everything else is the fact that it really places the emphasis, like we talked about, on the computer system and all the technology that goes into what those images mean. So in the operating room, we're constantly using those images for real-time feedback, preoperative planning, using LessRay stitching to measure our parameters, help us better plan and fine-tune our surgical plan for our patients, gives us real-time feedback as we're doing these big deformity operations as well to know we're doing the right thing, we're meeting our parameters, we're meeting our surgical goals. It's incorporating our EMG, our neuromonitoring into the system as well, which I think is an incredibly useful technique, and it just leads to less traffic, less work, flow in the OR of people in and out, and different devices and different machines, and we're relying on fewer machines to do our jobs. But from your perspective too, looking at the minimally invasive side of things, I mean, all those techniques are useful not just in a big deformity operation, right? They're useful
Yeah.
in a minimally invasive, a lateral, and anterior approach, a TLIF. All these things are useful.
Absolutely. For me, I mean, using it for that 1 and 2 level case or 3 level case and being able to look at the parameters now and measure them so I know exactly what kind of lordosis I need. I'm not guessing at what ALIF cage I want to put in, right? I'm not guessing at how much I want to dial up that TLX cage. I know what I want. I know I'm getting, because we're able to measure that in before and after, and I can feel really good that I didn't do a kyphosing procedure, I did a lordotic procedure. So for me, it's a huge benefit, I think, for everybody.
I mean, the future is endless for a machine like this, right? It's not the kind of technology where, you know, it's going to become obsolete in 3 or 4 years because there's a new thing that's greater and better and whatever else, you know, that's marketable. But with Pulse, you know, as new applications become available, as people start thinking about new ways to use this technology, those will be easily integrated into the system. And that is, to me, is a game changer, right? Yeah. If I'm a hospital system, if I'm a surgery center even, or a surgeon thinking about what technology I want to use in my operating room, I want something that has longevity. I want something that has possibilities and can evolve with times.
You know, every case you may only use 1 or 2 components. Some cases you'll use all the components, but
right.
You have them all there at your availability, you know, whenever you need them, and not have to bring in another piece of equipment.
Right. You know, I think these are the things that make it exciting because it's the only platform that is currently set up to evolve like that. What have you noticed from, you know, the operating room, how the teams are responding in the operating room?
I think the team's been great. I mean, it's integrated with the staff very easily. I'm all about being efficient. Yep. I want my day to be efficient. I want my OR to be efficient. So having, you know, one team run all of these things with their neuromonitoring and the 3D nav and the Bendini and everything being so efficient in one system, the OR staff has liked it. I think they really have taken that on. I think less ray for, you know, even if you're not a 3D nav person, just to have less ray, you know, and we're using it. The other iteration before we hit with Pulse, it was a little bit clunky and a little bit difficult to use it. And I have to say, with Pulse, it has been so much easier to use less ray on my ALIFs and getting so much less radiation for people on an ALIF, or if you're going to, you know, use X-rays for screws, when you dial in that image, and you can get such less radiation with every picture that you take. You can get right back to this spot that you want without having to take 3 X-rays to get there. I think the addition of less ray has really pushed it. It's so easily integrated where that makes it so easy for everybody.
Same thing with the Bendini. I mean, it's so much easier to use it. You don't have to worry, fire up the machine, wait for the right time. Less equipment, it's right there in front of you at your disposal whenever you want to use it.
You got to tell them 10 minutes before you're ready for Bendini so they can roll in all that equipment to do it. Now it's just right there.
Yeah. Just does make everything so much easier.
Absolutely.
You know, I think, you know, moving forward with Pulse, again, you know, what effects does this have on the future of spine surgery and the smart ORs? And I think what Pulse does, it puts everyone else on notice that this is the way it's got to be done, right? We are beyond the time where you could find one cool technology and bring that in the operating room and bring 5 or 6 or 7 or 8 or 9 or 10 other things into the operating room. It's really, you know, moving forward to improve efficiency and enhance, you know, what we're doing surgically. It's really got to be all on one platform. And
I certainly think it can be used as a marketing tool to say, look, I'm on the cutting edge of the technology. Like there are many people that aren't using the 3D navigation yet, which is amazing to me, because for you and I, it's kind of standard of care. We do it in every single case. So I think it will eventually become that standard of care. So when you're looking at maybe getting into the navigation world, you want to pick your machine wisely, right? You want to pick something that is not an old technology that may still work functionally, but you want to, you know, I think you would want to pick a new technology that's modular as Pulse. So I think it would be an easy sell to a hospital administrator to say, hey, this machine's going to really integrate our OR, make it the smart OR. It's going to be easy for everybody to use. We're going to be able to go out and tell everybody that we're doing this cutting edge, minimally invasive spine surgery. So I think for me, that makes a lot of sense for people that are thinking about changing or upgrading or getting into that market when they're currently not. So the Pulse kind of brings that together, and I think is a very sellable product.
The Pulse system is a really versatile system that can be used in many different features, but especially in the combination with the CO spin, it is truly magnificent and is definitely helping to improve my patient care. The space advantage is also a big issue. We don't need many cards anymore. We just have that pulse card in our OR, and this helps us to be faster, to have easier access, and to use it more often in our OR. And this is one of the main reasons why I really like to use Pulse in my daily practice.
The main reason is the navigation option, which proves to be very fast and precise, and with on top of that, well-navigated instruments. For example, the reference frame is very small in size, which makes it easy to work around it.
I chose the Pulse navigation system as a natural progression of my utilization of the Reline system. The inclusion of all modalities in a single platform is a considerable advantage for the whole OR team already so familiar with the Reline system. I undertake both primary and revision scoliosis cases in both adult and pediatric cases. Using the Pulse navigation system enables such cases to be undertaken in the safest gold standard environment, and hopefully this will be very much to the advantage for the patient and also for the operating team.
Our scientific affairs team provides essential support to the development and validation of new and existing products through regulatory processes and clinical evidence generation. It's part of my team's vision to prove the value of NuVasive innovation in clinical application and patient care. Today, I'm excited to share a study we released on the Pulse platform. We started this study because we believed that the accuracy, safety, and effectiveness of pedicle screw implantation could be enhanced through enabling technologies such as advanced imaging, radiation reduction, and navigation. A total of 12 fellowship-trained spine surgeons each placed 22 percutaneous pedicle screws from T8 to S1 bilaterally in 12 non-pathologic cadaver specimens. Reline MAS was used for all the screw placements, which were randomized per side. One side was Pulse 3D navigation and C-arm tracking paired with CO spin for 2D and 3D imaging, versus the other side, which was freehand fluoroscopy with the GE C-arm. The results of this study illustrated that Pulse navigation significantly outperformed traditional fluoroscopy. We found that screw placement on average was 34% faster with Pulse versus fluoro. Screw breaches with fluoro were 2 times more likely than with Pulse on average, and Pulse had fewer severe and medial breaches than fluoro, and mean radiation exposure to the surgeon using fluoro was 14 times more than when using Pulse. The improved screw placement and lower radiation exposure that we saw in the study reinforces the accuracy, efficiency, and safety benefits of the Pulse platform. Up next, hear from Mary on the cervical spine portfolio, C360.
We continue to make exciting progress with the C360 portfolio, our comprehensive, procedurally integrated solutions to the anterior and posterior cervical spine. First, with the ACP system for ACDF, then with the Simplify Cervical Disc for CTDR, and now with the introduction of the new Reline Cervical system for PCF. This completes the 3 strategic pillars of the C360 portfolio. For ACDF, we have made additional investments in the NuVasive ACP to expand our offering, providing even more options to address the nuances of anterior cervical fusion. With the additional plate sizes, screw sizes, and ancillary instruments, our ACP continues to lead with technology uniquely designed to address the common clinical challenges of ACDF and surgical efficiency. We are also looking forward to additions to our interbody portfolio. With the expansion of our Cohere product line, we are harmonizing our AMS interbody portfolio to better meet the needs of both you and your patients. For CTDR, I can't overstate the excitement around the addition of the Simplify Cervical Disc to the NuVasive C360 portfolio. We're executing on our commitment to become a market leader in cervical disc replacement. Our commercialization efforts have placed us on an incredible trajectory for growth with the most clinically effective cervical disc on the market. We're excited to have such an incredible Simplify surgeon team that have led the clinical studies around both 1 and 2 level indications. In just a few minutes, you'll hear directly from Dr. Richard Geyer, a principal investigator, on how Simplify is changing CTDR. And last but certainly not least, for PCF, I am particularly excited to talk about the launch of Reline Cervical, a significant step forward in our fixation portfolio. Shortly following this launch, we'll also have a Pulse software update to tie in Reline Cervical, allowing you to leverage the enabling technologies needed within one platform. Here with us today to dive deeper into the design rationale and his experience with Reline Cervical is Dr. Dan Rue from Columbia University. Dr. Rue, can you give us a little insight into the design of the instrumentation and what the team was focused on?
So we were interested in having a very simple system that's very easy to use and that's very versatile. And that's what we have. We have different kinds of connectors that allow us to bridge the junctions. We have lateralizing connectors and dominoes that allow you to go from the occiput to cervical, and then a second set that goes from the cervical to the thoracic spine. We have different types of rods, and all of these are low profile so that you don't have a big bulky system, and they have a very short run on the rod, so the TLIF heads are much smaller, and they have tremendous angulation, and you have all of these reduction screws that allow you to drop things down. I mean, I think Chris Shaffrey's the one that introduced me to reduction screws, and they really changed my life. It makes it so much easier because they're sticking out of the wound. You can just drop the rods down and put the set screws in to correct your deformity. It makes it all very easy, and with the repeaters to put in the set screws and the different ways of getting that screw to align by having rod reducers of several different kinds. That's the part that often becomes very frustrating because you got the screws in and you can't get the rods in. And we've made it so that it's very easy to do all of that.
Now, you mentioned some of the components of the system in the reduction screws, revisions. I know you have a case that you would like to share with us and how these different components and the innovation in Reline Cervical has impacted your practice.
Yeah, so this was a case of a teenager who had had surgery at another university hospital in another state. And afterwards, he said he couldn't swallow. Now, he'd had an anterior decompression done, and then they did an occipital cervical fixation in the back of the neck. He presented to me for a second opinion before getting another operation, and I looked at him and I realized that they had tucked his chin in too much. And so I said, I think all you need is for us to take out everything that they've done and realign your neck so that it's more upright, and I think you should be able to swallow pretty well. The great thing about revising this is that I had a whole bunch of different kinds of occipital fixation choices. So we were able to put our plate up high, and yet the plate is designed to have the thinnest possible plate so that it doesn't interfere, because otherwise people would feel back there and say, you know, I feel the instrumentation. So the plate is set up high, but the screws are set down low where it gets coverage by your muscles. And then we were able to pull out all of their other screws and use a larger diameter screw. So this was a 4.0 diameter screw they used in some places. We were able to use a 4.5 diameter screw. We were able to use reduction screws at C2 and at the bottom end of the construct, which made it very easy to drop down the rod. They used rods that were pre-bent, or they bent them. And I think that was the problem, because they just dropped down the rod and said the rod must be correct. Well, the nice thing about our system is that it has an articulation with a set screw, so that afterwards, after putting in all the instrumentation, I can just dial the head back to where it's supposed to be, then get an x-ray, and if it looks good, I lock it in that position and we're done. And that made the procedure very simple. I think it took us a little more than an hour and maybe 15, 20 minutes to do our part, and then plastic surgery comes in and closes the wound. It was a pretty short operation, very little blood loss, very easy to do, and to go from the occiput to the cervical spine and have everything line up beautifully, because that angulation, even if one screw is off like this, I can tilt the screw head to one side and laterally on the other one, and the rod just drops straight down. I can tell you that I've done a lot of occipital cervical cases over the years. This is probably one of the easiest I've ever done, and it was a revision in a patient who'd had a poor fixation the first time around with malalignment that led to this dysphagia. And immediately after the surgery, in the recovery room, I asked him, try to swallow. He swallowed, goes, I can swallow. And so it fixed his problem.
Thank you, Dr. Ru, for being here with us today in San Diego to talk about the final pillar of our comprehensive cervical portfolio, C360.
My pleasure, thank you.
Next, we'll hear from Dr. Richard Geyer with the latest on Simplify.
What I'm most excited about the Simplify disc and why it's now my disc of choice is that it has several advantages over all the previous discs. There have been 9 discs that have been approved by the FDA. The Simplify has been the 9th one, approved for both 1 and 2 levels. But what we learned from all the other previous discs were a lot of great information. For example, the kinematics. We know that some discs move more than others. Other discs may be more stable than others. But with the Simplify disc, it really reproduces normal range of motion of the native disc. If you look at kinematic studies, the center of axis of rotation of the Simplify exactly mimics that of a native disc. The Simplify also comes in 3 disc heights. It comes in a 4mm, which may seem strange to everyone, a 5, and a 6, which is more common. But as part of the Simplify study, we measured the actual heights of those patients undergoing disc replacement, taking the average of the anterior and the posterior heights of the disc, as well as adjacent levels. Well, it turned out that the vast majority of the patients, whether it was adjacent or the level where they had their disc replaced, measured 4mm or less. To illustrate some of the advantages of the Simplify disc, I'd like to present a 2-level case that I had recently done. This is a 43-year-old woman who had neck and left arm pain and also complained of bilateral hand numbness. So if we can look at our pictures here, you can see the C5-6 disc was pretty degenerative, and I just showed the axial on the one showing the stenosis. But more importantly, on the X-ray on the MRI scan on the right, one can see significant mild malacia. So this is not somebody that I want to do a metal artificial disc. This is somebody that I want to be able to study post-operatively should she have any problems or fail to recover as expected. So by using the Simplified disc that is MRI compatible and would allow me to still visualize the cord on both the sagittal and the axial images, I thought she was an ideal candidate for such a surgery. Now, fortunately, she has done well, and this is what her post-operative x-rays look like at the C4-5 and the C5-6. She was a little gal, and these are the 4mm disc heights, and they look large, but you can see that I didn't over-distract her facet joints, and I restored her disc height to the normal level that we see at the C6-7 level at the very bottom level. So while she is only 6 weeks post-op, her hand symptoms have markedly improved at least 50%. Her left arm pain is completely gone, and she no longer has the weakness sensation of her lower extremities. But I do know that I will be able to follow her if I need to by getting a follow-up MRI scan, say in another 6 weeks or 6 months or a year if I have to.
NuVasive is focused on solving clinical problems and driving value to you and ultimately your patients. This is what drives our dedication to excellence and innovation. We started with XLIF over 18 years ago, and we haven't stopped ideating since, which has led us to single position surgery. Our philosophy is built on driving efficiency into the OR through the utilization of less invasive procedures while the patient remains in one position. Since 2018, with our launch of lateral single position surgery and the X360 portfolio, inclusive of XLIF, XALIF, and X-fixation, we have seen a reduction in OR times, increased case volume, reduction in hospital costs, and most importantly, it has led to reduced time under anesthesia, reduced morbidity, and shorter hospital stays for your patients. NuVasive, in partnership with surgeons like you, continues to push the boundaries of innovation around single position surgery. We do this by capitalizing and innovating on our robust anterior and posterior procedural portfolios. From our clinically validated AMS portfolio with anterior and posterior porous PEEK and 3D porous titanium interbody options, to our minimally invasive access systems, or to our enabling technologies that support multi to single level cases, we aim to provide surgeons like yourself a holistic procedural solution. And now, we're taking our focus on single position surgery and advancing that into the prone space. As we continue into 2022, we are excited to enhance the workflow options for both prone and lateral single position surgery. These innovations aim to provide you with single position surgical options to access all levels of the spine. This versatility enables you differentiated surgical solutions to serve the vast array of pathologies that walk through your doors every day. Surgical options matter, but regardless of the surgical preference or the need that you have for that patient, we have a solution for you. And I'm excited now to introduce you to two of our surgeon partners, Dr. Alex Thomas and Dr. Ash Patel. And they're going to share a few of their case examples where they've utilized single position surgery and the latest NuVasive technologies.
2013, we had really worked out an efficient workflow for XLIF. We'd been doing XLIF for a long time, but I would completely wipe out all that efficiency when I'd have to stop and then flip prone for the screws. So we thought, literally randomly one day, we said, why don't we just keep the patient in a lateral position and put bilateral screws in and see how that works? And we've not gone back. And so now we can tie everything together with XLIF, XALIF, and X-fixation and do a complete fusion from the L5-S1 level up. It's been amazing. It really just started because I wanted to stop wasting time in the OR. That's really why it started. The staff loves it, anesthesia loves it. I know the hospital administrators like it because of the throughput and all of our patients going home the next day, but that was the most apparent aspect of it right off the bat, the saving time in the OR, but pretty quickly, even with just the XLIF and the screws experience, it became clear that it was more than just about saving time in the OR. Getting the patient out of the OR faster really did translate into improved patient outcomes. And you really see that when you can tie all three pieces together. So when you do the XALIF at 5.1, XLIF at L4.5, and then do the screws, and you never move the patient, and you do that in about an hour and a half, it's amazing. We still are amazed when we see the outcomes that we get. One of the bottlenecks in trying to get an increased adoption of this procedure is finding the access surgeons who are willing to do this. I think there's a little bit of apprehension of deviating from the traditional supine position, but I know if Mark were here, he would say that if he never had to do another supine ALIF in his career, he would be happy. It's easier on him ergonomically. He gets to sit down and do the approach, and the patients just do better. There's no other company that invests more time and energy into developing an educational curriculum, honing the skills of their faculty than NuVasive. You see surgeons come here and you can feel the apprehension when they get here, but by the end of the day, they're thrilled and they can't wait to go home and try this new technique in their own practice. You can actually see them start to relax as the course progresses, and that's all because of the CPD faculty and the curriculum that's been developed. So this is a patient in my practice. It's a real patient. It's a 68-year-old female, BMI of 23.1. She has no significant past medical history or surgical history, meaning she's had no abdominal surgery or gynecological surgery. She is a smoker, and she presents with severe back and bilateral leg pain, and it's worse with standing and walking, and she also reports subjective leg weakness. When she's sitting, her pain is manageable, but as soon as she stands up and starts to walk, it becomes unbearable. This is a sagittal T2 weighted MRI here on the left, and you have a spondylolisthesis at L4.5 with severe acquired stenosis, and there may be a superimposed disc herniation there, but also a spondylolisthesis at L5-S1. So I was never a big supine ALIF surgeon before single position surgery, so this was always the case that I struggled with. I mean, I'm such a huge believer in the power of these large intervertebral spacers that you can insert with XLIF. And so I would do this beautiful reconstruction from L4.5 and above, and then I would settle for the small spacer that you can insert with a TLIF. It never sat right with me. This, in my mind, is the perfect application for single position surgery. So you have a 2-level problem. You have severe stenosis. On the right, you have the axial cut through the L4-5 level, and there's complete occlusion of the spinal canal. Also severe central and lateral recess stenosis at the level below at L5-S1. Flexion and extension x-rays, I know they don't project that well, but take my word for it, there's instability on flexion versus extension at both levels. In the past, what was the good solution here? Is it a tubular TLIF that you do over the course of several hours at each level, or do you take the time and the morbidity of a 2-level ALIF? Here's the spinopelvic parameters. She's not terribly malaligned, although you can tackle more severe sagittal malalignment with single position surgery. In our hands, this is exclusively a single position surgical case. So we did a right-sided ALIF at L5-S1, followed by XLIF at L4-5, followed then by single position bilateral pedicle screw fixation. And importantly, I relied only on indirect decompression here. So even with stenosis as severe as this that you see on this axial image, you have to be a true believer in indirect decompression to maximize the efficiency benefits of single position surgery. And I found that as long as I execute the case correctly, meaning restore height or correct the spondylolisthesis, indirect decompression just about always works. Here's some intraoperative pictures. On the left, you see me working with the patient right side up with the XLIF retractor, working in a standard XLIF case. And then on the right, you see I'm putting the screws in. If you look closely, my assistant is on the other side of the patient, still closing the abdominal wound. So not only do you save time by not flipping prone by doing single position surgery, you can also work on the front and the back of the patient at the same time. And so I can get the screws in before that abdominal incision is even closed. The final case statistics, that was a 92-minute case with 22 minutes for screws, and that's a very average case time for us now, and it can be for people who commit to single position surgery. EBL of 50 cc's, and just like about every one of our other patients who undergo a procedure like this, she went home the next day with good maintenance of her spinopelvic balance and complete resolution of her back and leg pain by the 3-month follow-up. Here you see the Modulus XLIF and ALIF cages with the Reline MAS screws. And here's the lateral view showing the pre and post-op comparisons. I would argue that there's no other way you could do that surgery in even close to 90 minutes with any other surgical technique.
So my training is pretty traditional in the sense that I did open posterior-based surgery, open TLIFs. However, I wanted to migrate to more minimally invasive fashion of treating patients. My adoption first started with minimally invasive TLIF, but I always wanted to place a larger interbody cage. Lateral surgery makes a lot of sense, but I didn't want to deal with the flip and the positioning. So prone single position surgery just made a lot of sense to me once I started developing my technique around prone XLIF. The number one priority is to achieve the desired outcome. If that desired outcome is to use indirect decompression, place a larger interbody device, and be efficient in the manner in which you're delivering that care, then prone single position surgery will make sense for you. Because this is decreased anesthesia time for my patients, more of my patients in their 70s and 80s are getting this type of surgery. I've also had the ability to move my cases from a hospital to the ASC setting because of the efficiencies that we have. Performing prone single position surgery, and specifically XLIF, I use enabling technologies including neuromonitoring, specifically TMAPs, which gives me confidence that I can safely perform the procedure. There's a case of a patient who had pathology from L3 through S1, also a degenerative scoliosis, and then some foraminal stenosis causing leg pain. You can see from these pictures here that the patient has that degenerative scoliosis. The X-ray shows the curvature, which is mild, but what it's caused is some asymmetric disc space collapse. And we can see on the MRI in the next picture that's causing some stenosis on the right side at L3-4, bilaterally at L4-5, and L5-S1 on the left side. Now for me, as I approach this case, I need to think about decompression at all these segments. I got to think about restoring disc space height, decompressing indirectly, stabilizing the segments. I think about trying to accomplish this minimally invasively. There's other strategies that people may use, going anteriorly with an ALIF, but for me, this can all be accomplished from prone single position surgery. This is my plan. You can see that the XLIF was used at L4-5 and at L3-4. This allowed me to restore symmetry to the disc space and to provide an indirect decompression. At L5-S1, I performed a unilateral TLIF using minimally invasive technique, and then I placed my K-wires and my screws from L3 down to the pelvis in order to stabilize the segments in that position. Here you can see post-operative CT scans of what we accomplished. Good placement of screws and of the interbody device. And the final construct shows restoration of the coronal alignment, good lordosis from L3 through S1, and good disc space distraction, which allowed for indirect decompression. MASS TLIF 2 gives you the ability to perform open surgery through minimally invasive technique. The ability to hold interstitial distraction with the retractor blades gives you amazing visualization in the disc space, so that you can thoroughly clean, place bone graft, and then adequately fill with the interbody device. My interbody device of choice would be a TLX. You can expand the implant to 20 degrees of lordosis, which is substantial restoration when you're performing surgery at L5-S1 and L4-5. What differentiates NuVasive is the ability to treat both degenerative and deformity pathology. I treat these in a minimally invasive way using prone single position surgery.
While spine surgery has been around for decades, the way in which you approach spine surgery and its associated technologies have continued to evolve. That being said, we have continued to evolve. We are committed to outcome-driven designs. Through research and clinical testing, we have optimized products and procedures to enable better patient outcomes. From surface architecture-focused interbodies and biologics, to operative efficiencies with single-position surgery, we're just getting started. Today, I'll share with you what makes advanced materials science, or AMS, optimized synthetics, and single-position surgery regardless of approach, 3 key areas of innovation that you will want to incorporate into your practice. First, AMS. There's been a constant and growing interest from surgeons for spinal interbody implants that are capable of achieving direct fixation through osseointegration. More than 30 years of research has demonstrated that implant surface topography, not chemistry, that is material type, is the main driver of enhanced osteogenic response at the cellular level and greater osseointegration at the implant level. The literature supports 3 key conclusions related to the benefits of implants with interconnected porous structures. First, porous implants consistently achieve stronger osseointegration through bone ingrowth than solid implants with smooth or rough surfaces. Second, porosity enhances bone cell activation on both PEEK and titanium. And finally, unique and proprietary design and manufacturing methods are now capable of producing strong, durable spinal implants in PEEK or titanium, mimicking the porosity and stiffness of bone. To build on the importance of surface architecture, Atrax Putty, the NuVasive synthetic, bioactive, and osteoconductive bone void filler, last year was supported by a level 1 randomized trial as a bone graft substitute in spinal fusions. Recent studies have demonstrated that Atrax Putty performs comparably to autograft bone in thoracolumbar fusions. In addition, earlier this year, Atrax Putty received FDA 510(k) clearance for expanded indications of use with its comprehensive thoracolumbar interbody portfolio, which include our AMS technologies of modulus porous titanium, as well as Cohere porous PEEK. Atrax Putty is now the first and only synthetic to receive this level of clearance. Our AMS interbodies and Attracts Putty together enhance our thoracolumbar procedural offerings, inclusive of single position surgery. Speaking of, with the introduction of our X360 portfolio, and most recently XLIF Prone, NuVasive is able to support single position surgery from both lateral and prone patient positioning. Single position surgery improves surgical efficiency while substantially improving perioperative economics to the hospital through decreased operative time while meeting postoperative alignment and clinical outcome goals. The literature supports three main areas of focus related to the benefits of single position surgery, including first, operating room efficiency in a growing number of patients, second, the risks associated with intraoperative repositioning maneuvers, and third, the negative impact of repositioning on patient outcomes and hospital costs. Several studies have validated the use of single position surgery with XLIF and various types of fixation. Up next, hear from Enrique on the latest additions and updates to the posterior fixation portfolio.
As one of our key offerings in our comprehensive posterior fixation platform, I'm excited to introduce Reline, which was built on three core tenets: providing surgical efficiency, operative reliability, and delivering procedural versatility. Since 2015, we've prioritized continued investment in innovation within this portfolio, including such things as Reline Power, Reline Fenestrated, Versati, which has created the most comprehensive fixation system in spine, now capable of instrumenting from occiput to ilium in a single, seamless platform. Today, we are committed to becoming a world-class partner in spinal deformity and believe that together we can continue to evolve adult and pediatric fixation techniques, from enhancing methods to preserve and/or restore spinal alignment to offering junctional strategy solutions. We are driven by the mission of helping patients return to active and fulfilling lives. With even our youngest patients in mind, our pediatric portfolio has been expanded to bring you the right solutions across the spectrum of pediatric and adolescent spinal deformity. For the treatment of early onset scoliosis, MAGIC continues to lead the way with its cutting-edge magnetic growing rod technology that has completely revolutionized the standard of care. To complement MAGIC, we also have our Reline small stature system. And now, as we continue to innovate and partner with a team of world-renowned thought leaders, we are excited to bring you the next generation of deformity correction through our newest solution, Reline 3D. Regardless of your current technique or training, Reline 3D is designed to enhance your workflow through streamlined rod passage while providing a more powerful, simultaneous, three-dimensional correction across multiple spinal planes. Further, a key differentiator of Reline 3D is its versatility. With multiple tower assembly options, including screw pre-assembly, in situ attachment, and modular offerings, Reline 3D is our most powerful solution to tackle complex adolescent and adult deformity. Combined with increased procedural efficiency through powerful reduction and final tightening, along with seamless integration with our Pulse platform technologies, you have a comprehensive deformity solution to conquer even the most complex patient pathologies. One versatile platform, one fully integrated solution. And now I have the privilege of introducing Dr. Robert Cho, Chief of Staff at Shriners Children's Pasadena, who will be speaking to his Reline experience.
Hi, Dr. Cho. Thank you so much for joining us today. Always great to see you. Really excited to talk about your experience with Reline 3D.
I'm happy to be here. Thank you for having me.
You've been using Reline 3D for a few years now. Can you talk us through what some of your prior challenges were with adolescent deformity and also what initially attracted you to Reline 3D?
One of the biggest issues I think I had with any kind of complex deformity case was rod capture and rod to screw reduction. And I think that's pretty much a challenge with almost any system that's out there. And the reason that is because often we overbend the rods to a position where it doesn't fit easily into the screws that you've put in. And so there have been a lot of attempts to try to facilitate this reduction with lateral reducers or lateral translators. but there really hasn't been a really elegant solution that works for almost every situation. And so what really attracted me to Reline was that there was such a long throw in the reducer technology. I believe it's 110 millimeters, which is far and away more than any other system. And that alone obviated a lot of the problems that I encountered in the past.
How would you say your technique has evolved as you've gotten more comfortable with the system?
So as I've started to use this system, obviously with any system there's a little bit of a learning curve. I would say the first thing that I had to let go of in my own technique is to try to use the system exactly the same way as I've used other reduction devices. And I think the key is to allow the power of the reduction devices to do what they need to do to correct the spine. And once you kind of give a little bit of control to the reduction devices and to the system, then I think that's where you see the best results. So for me, it was just a little bit of being stubborn and doing it the way that I've always done it. And so it took probably 3 to 5 cases where I said, you know what, I'm going to let Reline take the wheel here and just use the power of the reduction devices to allow me to get the best correction.
I know some surgeons might have some hesitation on how difficult it might be to pass a rod through the towers. Has this ever been an issue for you? Do you think there's any curve that's a little too severe for this technique?
Yeah, if there is a curve that's too severe, I haven't seen it. Because of the reducing towers and the length of the reduction window, which is 110 millimeters, I've been able to pass just about any rod that I've been able to bend. And even with some crazy bends that I didn't think would make it through, there's enough flexibility in that window that you can pass just about anything. Even with my first case that I did with this system, I thought it was going to be very difficult to pass the rod, but the passage of that rod probably took somewhere between 30 seconds to a minute. And if you compare that to the way I used to do it, which is to either put the rod into the screws, put the reducers on, roll the rod in space like a Cottrell Dubusse derotational maneuver, or to hold the rod in sagittal space and then try to really push hard to get the reducers into the screws, I think it takes much less time. So it's one of those things that I think you have to try to experience.
We've talked a lot about efficiency and the importance in trying to make your workflow as efficient as possible. Can you talk through how the Reline 3D has helped you to have a more efficient intraoperative workflow?
Yeah, I think the biggest thing that Reline helps you with as far as workflow is that you can use a single tower to do multiple steps. So you don't have to spend time putting a tower on or off the screws. You can use that same tower to help reduce the rod to the screws. You can use that same tower to help do your derotational maneuvers, and you can use that same tower to put your set screws through and torque your set screws through the same tower. And so because of that, I think you're doing a lot less instrument transfer with your scrub techs. And that alone, I think, has been a huge boon. That said, there's other efficiencies that are built into the system. The way I usually do it is I will actually have the reduction towers attached to the screws when I put them into the spine. And that alone saves me a few minutes because I don't have to look for the towers and I don't have to put them onto the screws to get the reduction that I want.
What's your philosophy around rod selection with your adolescent cases?
So with most adolescent cases, I try to go for as stiff a rod as possible. And usually that rod stiffness is a combination of rod diameter and rod material. And so the stiffest rod diameter and material that I usually use is a 6.0 millimeter cobalt chrome rod. And that usually provides enough stiffness for me to create the type of differential rod bend that I want to derotate the spine in a three-dimensionally accurate position. Now, sometimes you do these cases and patients have challenges. Either parts of bone are missing, like pedicles that are very small, or if the bone quality is really poor, then I will consider using either a smaller rod diameter or different material or both. So in situations where the rod diameter makes sense for that would be if you have a patient who has a syndrome or some other issue that makes the bone quality poor. Cerebral palsy patients often have poor bone quality. Patients who have connective tissue disorders sometimes have poor bone quality. And sometimes you don't know until you get there. Sometimes I've had sedentary adolescents who have had really poor bone quality, and those patients are the ones that you make that intraoperative decision. And the beauty of the Reline system is that you can mix or match. You can really go as stiff as you want, 6.0 millimeter cobalt chrome, or you can go much more flexible, which will protect your bone screw interface, like 5.5 millimeter titanium.
Can you talk us through how you think Reline 30 helps you to achieve a better three-dimensional correction for your patients?
That's a good question. I think the biggest issue that I see with most rod systems is that the rod flattens out significantly when you're trying to reduce the screws to the rod. And part of that is the rod stiffness and diameter, like we talked about. And some of it is also just when you place the rod into the screws, the rod flattens out. I think that if you put both rods into the screws and reduce them at the same time, you're putting less load on each screw. Because you're putting less load on each screw, that rod deforms less in three-dimensional space. And that alone provides a lot of the three-dimensional corrective maneuver that I need to do.
Dr. Joe, thank you so much for coming down from LA to talk about pediatric deformity with us.
Thanks, Julie. It was awesome being here.
Always a pleasure. And next, you'll hear from a handful of Reline 3D users and their thoughts about the system.
What better way to distribute loads is to go ahead and have guides that are attached to each anchor point that you have and have them attached bilaterally. So now you're able to distribute load rather than having it on one screw or two screws or three screws. You have it essentially distributed throughout the spine, and that allows, first of all, to maintain your bone screw interface and your screw integrity, and then secondly, to gradually get correction.
If you think about the spine surgery or the correction of scoliosis, there's a million steps. And if you've ever been in a OR during the sort of rod to derotation phase, there's a million tools. They're being passed back and forth. When you're doing the correction, you're passing instruments back and forth. You're passing reducers back and forth. You're passing pile drivers back and forth. You're the segmental racks, and trying to get it all hooked up. Every single one of those steps takes additional time. And so the more you can streamline that workflow and reduce the number of steps, we'll get that kid off the table faster.
I'm a big believer in direct vertebral derotation techniques as opposed to on block, and I think one of the hallmarks of this system is it allows me to have towers in place after screws are in that we can fine-tune after the initial correction has been made, and gives you instant real-time feedback of where the axial plane is going to end up.
NuVasive is the industry leader in training and education. Your clinical education is so important to us. Our clinical professional development goal is to provide an unparalleled learning experience by educating surgeons on less invasive techniques and enabling technologies to improve your overall outcomes. Now, with dual premier training sites on both sides of the United States, our CPD programs are reaching more surgeons globally to ultimately impact the lives of more patients. Our new East Coast Experience Center, which opened last fall, adds a level of convenience for those of you practicing on the East Coast or internationally, making it that much easier to attend an in-person training. But to continue providing you the most flexibility in training opportunities, we offer remote and in-person, competency-based, and cadaveric trainings featuring esteemed faculty mentoring and virtual reality technology. Regardless of your location or your procedural approach or your years in practice, we have comprehensive procedural systems and a talented set of CPD surgeon faculty, all for your clinical development. Since November, we've been offering additional courses specifically on procedures powered by Pulse, allowing you to experience how enabling technologies can integrate with your procedural approaches to advance your surgical outcomes. An important distinction I want to make is that we call ourselves clinical professional development for a reason. Our primary objective is to push the boundaries of clinical education to develop those we partner with, inclusive of our own sales force, because we know that if we use the same tenets and rigor in our own commercial teams, it will provide everyone with a better operative experience. And with that, I'll hand it back to Massimo to close things out.
Thank you, Paul, and thank you to all of you today. We have an amazing portfolio, paired with clinical education and supported by clinical data. Our enabling technology platform, Pulse, is now being used around the world, providing its utility in all types of spine cases. Our C360 portfolio, including the upcoming posterior fixation system, Reline Cervical, our thoracolumbar portfolio, which is the most comprehensive in all of spine, featuring X360 and our TL posterior solution, and our complex portfolio, giving you a solution to take what you're doing now and enhance it with Reline 3D. We share the same goal with you, to help change more patient life. We can wait to get this latest procedural innovation into your hands and see the amazing thing you will do with them in your practice. As Paul said, our CPD team is here to support you. Please take full advantage of the industry-based education. Now, in closing, thank you for joining us. Stay safe and take care.